This was definitely a rare occurrence. When viruses mutate, they excuse me? Okay. So when viruses mutate to become more contagious, they're usually less deadly as well. However, leave it to COVID to break the rules. This spread throughout India, leading to significant loss of life, social upheaval, and economic strife. This spread throughout the Asian continent and eventually made its way to the USA. May 7, 2021 was the first documented case of Delta in the US arising out of New York. After 6 to 8 weeks, Delta became the predominant variant, leading to another surge of cases, however, not as drastic due to the help of vaccines. Those sickest were largely the unvaccinated, and it was quite rare to see a vaccinated individual become significantly ill. During the latter part of September and early October, cases began to dwindle in the hospitals again, and many believed the light was truly at the end of the tunnel, especially as another round of booster vaccines were being pushed to ensure adequate protection. However, as we've learned time and time again, COVID has other plans. So a new variant was noted in South Africa on November 24th, 2021. This new variant was quite different than the rest. Omicron had 32 mutations to the spike protein, which led to increased immune and vaccine evasion along with increased transmissibility. The doubling time of this virus was 3 to 4 days, which means if you have 100 people who are infected, then in 3 to 4 days, you're going to have 200. And then again, in a couple days, 400, and then so on and so forth. This moved much faster than we had seen any variant move before and became the predominant variant in the United States in our community in just a 2 to 3 week period of time. At the end of December, we had reached over 90% of cases reported as Omicron. This moved so fast through the community that I knew more people infected with COVID than I knew people who didn't have COVID. It was definitely an odd and crazy perspective. However, there was one silver lining. This variant appeared to be much less severe than the previous variants. Although many more people were being infected on a daily basis, the percentage that became severely ill was still minimal. This data that you see here is from South Africa. However, US studies show similar trends as well. Mortality, hospitalization, and severity rates were all decreased compared to Delta. And again, the unvaccinated were largely the population of people who would get severely ill and require hospitalization. However, the hospitals around the country were still put under a tremendous amount of pressure given the magnitude of people becoming infected. Hospitals had to impose strict visitor restrictions and triage methods to ensure the safety of their staff and patients. The surge continued for a few weeks. However, it appeared that as quick as Omicron spread throughout the community, the numbers waned almost just as fast. So here we are now. The numbers have waned dramatically and it appears that things have finally calmed down for a bit. Personally, I haven't seen a COVID-19 patient in over a week, which is a stark contrast of where I was 3 to 4 weeks ago, where 90% of my day was filled with COVID-19. There are still about 1,000 to 1,500 cases daily, 60 to 80 hospitalizations, and 20 to 30 deaths. But again, that's a stark contrast from only a few weeks prior. Okay, Dr. Farnfar, you can take over now, your part, and then I'll swing back when Dr. Belani's done.
Okay. Sure.
Okay. So my part is what is the clinical spectrum of the COVID infection? And
One second. Can you stop the screen share? Okay, good. Who is going to talk now? Dr.
Yeah.
Dr. Farnfar.
Dr. Farhan. Okay, give me 1 second. I don't see him here. Okay, I see him here. Okay, Dr. Farhan, you're on. Thank you.
So my part is clinical spectrum of COVID infection. and then what happens if you end up in the hospital. People with COVID infection can have a whole spectrum of illness. They can be asymptomatic, they can have mild illness, they can have moderate illness, or they can have severe illness requiring to be in the hospital, or even in the ICU on a ventilator. Things that we use to evaluate this includes blood tests, like a complete blood count, liver function test, kidney function test, some inflammatory markers, some blood tests that show inflammation in the body as COVID causes an intense inflammation. And these include C-reactive protein, D-dimer, and ferritin level. Things that decide who will have mild disease, who will have moderate disease. People with comorbidities are at higher risk of having more severe disease. Some of these comorbidities include age greater than 65, heart disease, chronic lung disease, diabetes, cancer, obesity in and of itself without including diabetes, chronic kidney disease, smokers, and people who are transplant recipients. Now, first I'll go over what constitutes asymptomatic, mild, or moderate. Asymptomatic infection are people who have no symptoms. It's hard to say what percentage of people are asymptomatic because they don't even know that they have an illness. But if they're tested for whatever reason, they will test positive. And mild illness, those may show a variety of signs and symptoms. They can have a fever, cough, sore throat, fatigue, headaches, muscle pain, nausea, vomiting, diarrhea, loss of sense of taste and smell. They usually don't have shortness of breath, and if you do a chest X-ray on them, they have normal X-rays. These people usually don't go to the hospital, don't go to the emergency room, and can improve at home without, without any further symptoms. But people with the comorbidities that I mentioned before have a chance to then progress to moderate or severe disease. Moderate illness is if there is a lower respiratory tract infection with the virus. And these symptoms include low oxygen level, down to about 94% on room air. You can have mild infiltrates on the X-ray as well. These patients can go like this and improve, over a period of 1 to 2 weeks, or can progress to severe disease rather rapidly. And that's why these patients should be monitored closely. And what I would tell my patients at home who call me and say that they have tested positive for COVID-19 is that to get a pulse oximetry and measure your oxygen saturations. And if it looks like it's dipping below 94%, not way below, but once they get to like 92, call me, because if you wait until it's too low, then it may be too late and they may get very sick. Then the severe illness is when your oxygen level is less than 94% on room air. Most patients have rapid respiratory rate of over 30, and chest X-ray shows more than 50% of the lung fields have infiltrates. In these patients, oxygen therapy should be started immediately. And because COVID-19 causes intense inflammation, and it's this inflammation that actually causes worsening of symptoms, they're started on systemic steroids and sometimes also empiric antibiotics because there is sometimes bacterial co-infection. Now, after severe illness, then these people usually are in the hospital, possibly on a regular medical floor. It's critical illness. Patients who are critically ill cannot maintain their oxygenation with the help of nasal oxygen and require higher amounts of oxygen with venti mask, BiPAP, or high flow oxygen. During the first wave of COVID infection, we very quickly would escalate the management of low oxygen saturation to intubating people and putting them on mechanical ventilation. But experience told us that patients actually get worse by doing this, and by using some clinical tricks to improve oxygenation without putting people on a mechanical support, they actually would do much better. Now, what to expect if you're admitted to the hospital? When a patient goes to the emergency room to be evaluated, one of two things can happen. Patient can be deemed not to be sick enough to be in the hospital and would be sent home, telling them to be careful, monitor your oxygen saturation, and if you go below 92%, to come back to the hospital. Or you would be admitted to the hospital. In the emergency room, patient is categorized in one of the above categories. In the hospital, it's usually moderate, severe, or critically ill. And if you're moderate disease, they will be admitted to regular medical floor. It will be seen by the primary physician, usually the hospitalist, an infectious disease specialist, and a pulmonologist like myself. Patients are evaluated frequently during the day by the nursing staff and at least once a day by each of these specialists. If the patient continues to improve, they'll be discharged home. If at any point they seem to be progressing to or regressing, then they would be upgraded to the more appropriate floor. Patient with severe disease would be transferred to step-down floor, where the nurse-to-patient ratio is smaller and you can be under closer observation. They will have continuous oxygen monitoring, as they may deteriorate into critical category very quickly. On this floor, they may require higher flow rates of oxygen, including a mask oxygen, which can give you almost 70–75% oxygen, high flow oxygen, which can go up to 100% non-invasively, and a BiPAP, which is a mask that most people know from sleep apnea, but we can force oxygen into patients' lungs and improve their oxygenation. If patients can't be oxygenated adequately with these modalities, then they'll be transferred to the intensive care unit. In the intensive care unit, we again try to avoid putting patients on ventilators, and will have them do what is called as a prone ventilation. That's patient laying on their belly. For some reason, COVID inflammation seems to affect the back of the lungs. And if you're laying on your back, the blood supply with the help of gravity will get to the more diseased part and your oxygen level drops. But if you're laying on your belly, the front has the better air sacs, and then the gravity will bring the blood next to that and oxygenation improves. If none of these works, and then patient will be intubated, then we'll put them on mechanical support, but we'll try to avoid this if at all possible. At any point along this way, if the patient starts improving, then the care will be slowly de-escalated until the patient is ready for discharge. Next.
Okay, next is Dr. Balani. Can you please hit the mute button, everybody?
Can you guys hear me? Okay.
Yeah, we can hear you.
Great. All right. So thank you very much for having me today. My topic today is going to be on the therapeutics of COVID-19. I know my first two speakers have been very much extempore and going without any slides majority of times, but I'm pretty slide heavy at this point, a little bit more didactic in nature, just because I wanted to show whatever was new this particular year and what options we have as an outpatient to try and prevent us to get into the hospital. My talk also will actually start with a little bit of the vaccine data that we have. So starting forward, this is the data that we have based upon the age of a particular patient and the risk of COVID-19 of hospitalization and death. As we can see, where the reference group is the 18 to 29-year-old, the hospitalization rates increases as you go have a 10-year higher incidence. So with the hospitalization rates from the reference rates being 0, it goes up to nearly 8 to 10% higher, 10 times higher in those who are age 75 and above. The same holds true also for death associated with a higher number of nearly 140 to 340 times the reference range as you become 75 and 85 years of age. So what does that tell us? It tells us that as we get older, we really do need to be careful about the disease progression of this particular disease, which usually is very mild in the general public. So non-pharmacological preventative interventions really have not changed much. It is the same regarding, you have to be able to test yourself, get diagnosed early if you have the symptoms, stay safe and isolate so that you don't cause this particular infection to spread ahead. Wash hands, maintain some distancing, wear masks if you are infected, disinfect the frequently touched surfaces, avoid crowds, close contacts, and of course, most important is get the vaccine and the booster. So I think Dr. Marco kind of touched about it, but I'm looking at it with a little bit of a tweak to it regarding the number of cases, the rate of COVID-19 cases based on the vaccination status. So as you can see, in the left side of the graph is the cases and the right side is the deaths. The black bar is those who are unvaccinated and the blues are those who are fully vaccinated. So we can definitely see with the Omicron in January of 2022, there's a very high spike of those who were unvaccinated as compared to the vaccinated host being nearly 14 times higher risk of dying from COVID-19. On the right bar is the deaths, as I mentioned to you, again, with the fully vaccinated host as compared to the unvaccinated host, it's a very big splay that you can see regarding the death associated with it. Now, taking forward, in those who are not only fully vaccinated, but they were fully vaccinated with a booster. So if that is the solid line versus the blue dashed line is the one without the booster. You can again see that particular difference is even further made more severe with a 41% chance, 41 times more risk of dying from COVID-19 in the unvaccinated group as compared to those who were fully vaccinated with the booster. So as we've seen different variants, and Dr. Marco kind of went over those over the period of time. In November to December to January, Omicron has been the most common one, and it is the current variant of concern, which thankfully is now coming down as the cases have really phenomenally dropped down the last few weeks. The BA2, we'll talk a little bit more about it, but possibly BA2 may be something that we have to keep a watch on. But as of now, it is not considered as being a major variant of concern. So what do we know, and why is it that these variants are important, or the constant surveillance for the variants are important? We need to know that with these variants, are we capable of evading the new infections and new variant infections that come along? How effective are our current armamentariums against them? So if you look at those patients who had the data with the mRNA vaccine, the vaccine effectiveness is lower from the hospitalization. So the ones in the square bars are the ones with the Delta variant, and the ones in the round circle bars are the ones with the Omicron virus. So as you can see that those patients who had 2 doses for either Pfizer or mRNA, they both definitely had a lower efficacy of the vaccine as compared to the Delta variant. So there is some evasiveness of this particular virus with our current spike antibody proteins. But if you were to give them the booster, if you were to give them the booster to both either the Pfizer or the mRNA vaccine, you can see that that particular bar, even though slightly bit lower, the vaccine effectiveness slightly bit lower, is definitely better than the 2-dose regimen. So again, we're getting it closer to the effectiveness of nearly 80 to 87% effectiveness with those with the boosters and the Omicron. And thus the decrease in the rate of the deaths and cases in those who were fully vaccinated and boosted with Omicron. So prevention strategies against the Omicron variant. Thankfully, we don't really have to go much into it, given the fact that Omicron is probably on the tail end at this point. But just be aware that vaccination is recommended for everybody who's an age of 5 and above, and booster is recommended for everyone who's ages of 12 and above. I'm going to talk about 2 subpopulations regarding the immunocompromised host, those who have, as Dr. Farfar was talking about, the different scenarios where you can make your immune system not be able to produce the antibodies as much and as robustly as you would have wanted to. So that subgroup of patient population, the immunocompromised patients, and then of course the younger kids who do not have the ability of getting the boosters. What do we do different, or what can we do different in those patient populations? So I'll talk about that again in the next slide. So Pfizer is currently recommended for ages 12 and above with the 2-dose series. From ages 5 and above is also Pfizer. Moderna is only approved for ages 18 and above. And the Janssen virus vaccine is a 1-dose vaccine, which is approved for ages 18 and above. At the current time, Janssen probably will not be around for too long, given the fact that the production has been halted in the US. So it's going to be probably more of the mRNA vaccines that we're going to be looking at. Down the road, we do anticipate other vaccines to come around, specifically the one probably closer to the mark is going to be the Novavax. Now, all of these vaccines are intramuscular administrations. They're given to you in your arm. You can get some local soreness from it and just local vaccine-associated issues. You can also get some side effects with severe fevers, chills, fatigue that you can feel. There's definitely more response and antibody response when you have either seen these vaccines in the past, plus you've had a natural infection associated with it. So again, the more robust the response of your symptoms associated with the vaccine, it's not because you have the COVID infection, it's because your body is recognizing those antigens and producing an immune response to it, showing a very good, robust immunogenicity. So it's actually, a rose with a thorn. You really want the thorn to really show up, showing that you have a good response to that particular vaccine. In those patients those kids who are 2 years and older, and yet not eligible up till 5 years, who are not yet eligible to get the vaccines at this point, wearing a mask in the public spaces and around people who they won't live with is probably still prudent. I know there have been the most recent policy has been to remove the masks from normal general public, but I would strongly recommend to be aware of your own risk of having or getting COVID infection, because that personal risk is what is going to make you responsible enough to keep that mask on or off, depending upon the situation. With boosters, so why are boosters important in these immunocompromised hosts, and what did the CDC do different in this patient population? So there was a study that was actually presented in the Nature by Dr. Takar et al. In March of last year, which showed that after natural infection within 90 days, you definitely had a decline in that spike antibodies in those patients who had cancers. The liquid cancers, the heme malignancies like leukemia, etc., or the solid organ transplant, solid tumors like lung cancer or breast cancers, etc. So they did find that there was a decline in the amount of the antibody response that your body made. And that antibody response further declined in certain subgroups of patients, especially those who've had things like Rituxan, which is a CD20 therapy, or had a stem cell transplant, or had T-cell depleting treatments with the CAR-Ts. So there was a decline after natural immunization. That same study was then again presented in August with a population of those patients who had taken the 2-dose vaccines. And they also found that even in that patient population, there was that's an error. The second blue bar should actually say response post 2 doses of mRNA. And that too was a decline in that particular patient population. And the third study was actually on those with the boosters. And the boosters also showed that there was a decline in the rate of antibody responses to the vaccines. So having seen a decline in that antibody response, the CDC has actually come up with an additional 3rd dose of the series. So in those patients who are immunocompromised, so those who've got cancer, who's got transplants, who've got rejection treatments in the recent past, who are currently on chemotherapy, or have severe immune deficiency syndromes that don't allow the host to make the antibodies. So your immune response is lower because you can't make those antibodies. Those patients should actually get 3 doses, 2 to 3 weeks, 3 to 4 weeks, depending upon whether you're getting Pfizer or Moderna vaccine. You should get 3 doses to complete a primary series. And then subsequently later, 3 months after, get your 4th dose, which would be actually the first booster dose for you. So in those who are moderately or severely immunocompromised, the primary series has 3-part doses, and then the 4th dose is the booster dose. So that's something which is relatively different and is new in the last few months. And definitely the interval is definitely new since actually last week. So, and the children, those children who, why is vaccines important for kids, right? So in kids get infection just as much as the adults do. But kids luckily are not as sick, but some can get sick really with this. There were nearly 8,300 deaths of children between the year from January to November of 2021. That's a pretty high number of things. It's a top 10th cause of death in 2021. So it's not something which is really mild. It is something which is pretty significant. And thankfully, we don't see that illness happen so fast. And therefore, we're not that worried about it. But definitely, kids are a big reservoir of infection and really get sick with these. They're both short and long-term health complications. There have been associated long haulers, even in teenage kids. So we do see that patient population getting sick with COVID infections. not only do they get sick with infections, they're relatively mild, and if they're not screened or tested, they can actually spread this disease very easily in the congregate setting, especially with the schools and or with games and areas where there are much more close contacts at. They can also bring the same infections back to maybe their homes, which could be a multi-generation homes, where the older generation in the families could actually be getting the brunt of the severe disease. So again, trying to stop that particular mode of transmission is also just as important. So not just for the kids' safety, but also for the kids' safety around them. There is something called the multi-system inflammatory syndrome condition, or MIS-C in kids. Now, this is a very severe condition where the kids actually get admitted to the hospital and have a severe response of inflammation and a multi-system involvement, and thus the name. It usually involves the heart. The child can have a very, very rapid heart rate, very low blood pressure. They may require to be in the intensive care units. They may require various medications to keep the blood pressures up. It can affect the kidneys. It can affect the eyes. It can cause conjunctivitis and red eyes. It can cause severe diarrhea, abdominal pain. And these kids are really sick and require intensive unit therapies with high dose of prednisones, etc. Thankfully, so far, based upon early diagnosis and treatment, these children have been able to the fatalities associated with this particular disease is relatively mild, but they're quite critical and they do turn around very well post-steroids. So again, it's really, vaccines are going to be important no matter which way you go. So that is our virus-directed preventative therapy that we have. But suppose you do get the infection of COVID, then how do these current therapeutics that we have at this particular time help us? So Dr. Farfar pretty much went over the situation when you actually step into the ED and there forward. But what happens between the time that you get the infection and you are in that initial phase of your infection where you're not so sick? It's very early on where the virus is really replicating and causing the troubles. They're causing symptoms that are currently present with mild symptoms. It could be sore throat. It could be with the Omicron, we definitely saw more upper respiratory tract infections. So more fevers, more sore throat, more diarrhea, more achiness and muscle ache and fatigues. So when you have this early infection rate where the viral phase is very high, what can we do and what opportunities do we have to try and prevent the progression of disease? Now, taking this forward, I just want to make sure that we understand that these particular medications that we have are not for those who have severe or moderately to severe disease. These particular medications are for those who have no problems with breathing or shortness of breath. So if you have these red flags of severe shortness of breath or difficulty breathing or pain or pressure in the chest or cold, clammy or mottled skin or confusion or becoming difficult to rouse or blue lips or face or little or no urine output, coughing up blood, neck stiffness, non-blanching rash, etc. These red flags are not candidates for treatment. These people need to get to the ED. So when you are still very mild, you can probably potentially go on to have the treatment options given to you. Now, majority of patients who have COVID are very mild and they do not require any treatment. Supportive care is the best way for them. So whom do we actually look for who require disease treatments, right? These are the patients who actually have a risk of disease progression based upon their baseline characteristics. For example, they're immunocompromised, they're these cancer patients, they're older patients. Anyone who's unvaccinated at this point, regardless of the age, is a very high risk of disease progression. If you're pregnant, you are at disease progression. If you have any comorbidities, you're obese, you have diabetes, you have asthma, you have seizure disorder, you are on steroids, any of these systems where you have other disease presentations at baseline, you have a chance of disease progression. And in that situation, and only in those situations, do we actually consider treatment options. And what treatment options are we looking at this point, right? So there are four major, there's actually a fifth one, which is not included as yet because it literally came out last week, but I'll talk about it again. I'll give you the name about it. But there are four major possibilities of treatment options. And even amongst these four, pretty much number one and number two are the most commonly utilized agents at this current time. So nirmatrelvir or Paxlovid is the other name for it. Is an oral medication. And how does it help in these patient populations, right? So why is it important to take this? We are going to, the way to look at any of these treatment modalities is to see how effective is it in preventing disease severity, in preventing disease progression, in preventing hospitalizations due to severe disease or critical disease. So in the case of the first options, which is Paxlovid, it has a relative risk of reduction of 88%. Same thing with Sortomavir, pretty high at 85%. Same thing with Remdesivir, pretty high at 87%. Molnupiravir is not as high, it's about 30%, but there is a small niche for that particular medication, and I'll talk about that. So the major pros and cons of these particular illnesses is based upon the efficacy of that particular medications, as we mentioned about the risk reductions, right? Then the second part of it is how easy is it to take these medicines? So with the first option, it is pretty good. It is an oral regimen. It's simple to do, right? So you just take the pills twice a day and you have a good efficacy in 5 days, you have a good outcome. With Sortomavir, it is an infusion. So you have to get to an infusional place. You have to go to the hospital or one of the infusion centers where that is available to get the infusion. It is only a one-time infusion, but it is over a 3-hour period that you have to be there. So you have to be able to get to a particular place, get the infusion and leave. The third, Remdesivir, is great, but it has to be admitted in an IV setting. So it has to be given intravenously consecutively for 3 days. So majority of times that is done in a hospital setting. Molnupiravir, again, is an oral regimen. So again, it's great. What is the downside of these medications, right? So with the first medication, the most important downside is its drug-drug interactions. Unfortunately, it has a lot of interactions with the very common occurring medications. For example, you want to have somebody who is going to have other comorbid conditions. So you can have somebody who's a heart disease and takes an antiarrhythmic, for example, takes amiodarone, etc., for the heart rhythm. Unfortunately, you can't use this drug. Somebody has kidney problems, severe kidney problems. Unfortunately, you can't get this medication. Somebody has liver problems, you can't get this medications. There are drug-drug interactions with calcium channel blockers, there are drug-drug interactions with transplant medications. So there are many medications that it does interact with, and thus it has to be very carefully looked for in requirements. With Sortomavir, it is an infusion, you have to get there. With Remdesivir, you have to be an inpatient to get that. So again, it's not very practically available. Molnupiravir, it does have teratogenicity, meaning there is a possibility of harm to an unborn fetus. So if you are pregnant, you are not allowed to get that medication, and neither is it recommended for young children. So there are caveats for every medication that is around. So what I'm going to do is kind of go through a flow diagram if you are positive and how do you think about it as to how to go about it over time. So if you have turned to be COVID-19 positive, the most important thing is, remember, it's an early disease treatment, right? So if you have high risk, you are unvaccinated, you've just been diagnosed, you're within that first week of illness, that's when you need to be thinking about these treatments so that you don't go to the second phase, which is in the second week of your illness. So if you're within 5 days of symptoms and no major kidney, liver disease, no major drug issues, then, and if Paxlovid is available. Now, what do I mean by that? I can write a prescription, but unfortunately, the medications are not as accessible as we would like it to be, especially with the Omicron phase in December and January. it was tough to meet demand. There were just so many patients that we really did not have the medications to be able to give them. So we really had to stratify their illness requirements because it was just supply demand issues. As things have gone better, as the number of cases have gone down, I would anticipate this medication now to be more readily available. So if it is available and you're age 12 and above, and you've checked your drug-drug interactions and you're all good, we do have a difference in dosing of this particular medication. Normally, it is given 3 tablets twice a day for 5 days. But if your kidney functions is mild to moderate, mild insufficiency, it is dropped to 1 tablet twice a day. It's dropped by 1 tablet, so it's 2 tablets twice a day. If your kidney functions is less than 30, you're not allowed to get this medication. And then there are only certain pharmacies that have this medication, so you have to make sure as to which pharmacies you're going to be going to. Now, if Paxlovid is not available and you're still within that window, you could potentially get the monoclonal antibodies. The second monoclonal antibody, I talked about sotrovimab. The second monoclonal antibody, which has similar protective nature, is called bebtelovimab. It just literally came out a week ago. They're both one-time infusions, so you have to get to that particular center, the infusion center, to get that. You have to be age 12 and above for even to get this particular medication. In those who are pregnant, severely immunocompromised with cancer treatments, etc., this particular route is probably benefited more as compared to Paxlovid, or is preferred more as compared to Paxlovid. So we do prefer these in that, especially those 2 populations. If your COVID-19 is past the 5 days, you cannot get Paxlovid. So in that situation, you have to directly go towards the monoclonal antibody arm to be able to get that. If you're past the 10-day window, then supportive care is the only options for you, and just watching and keeping, as Dr. Farfar was talking about, watching your respiratory rates, watching your overall symptoms to see if there's any disease progression. Now, the other options, as I mentioned, was also that if you're still within the 5-day window and Paxlovid or the monoclonal antibody is not available, then you could consider the possibilities of molnupiravir. So it's a third line treatments for us, given the fact that it's only 30% risk reduction, but 30% risk reduction is better than 0. So in that patient population, provided you are not pregnant, your age is above 18, and you're not breastfeeding, then you can go ahead and get this particular medication for 5 days. Now, if for whatever reason you were admitted to the hospital, you had a broken bone or whatever else, and they found out that you had COVID, incidentally, it was picked up that you had COVID, you're still okay, but you have significant risk factors, you are unvaccinated or whatever. So if you're already inpatient, then remdesivir is a good option. It is it's a dose to be given daily intravenously for 3 days. It has a very good high rate of risk reduction in that particular time period. So that particular flow diagram kind of gives you the various options that we have for early treatment during the viral phase, because again, what we're going for is either as an antiviral with the oral medications or remdesivir, or we're helping your immune system by boosting your antibody response by giving you the monoclonal antibodies. So those are the 2 main treatment options that we have at this point for the current COVID-19 treatment patients. Now, I did put this up slide again. So if all of these situations are not applicable for you, or you don't have Paxlovid, you don't have the monoclonal antibodies, you don't have the molnupiravir, and you're not admitted to hospital, there is a particular trial going on, which is called the Active-6. It's an NIH-based trial where you basically call in a particular number, and it is looking for, it's recruiting patients who are 30 and above and who've been tested positive in the last 10 days. And it is basically, once you call this particular number, they will enroll you. Everything is done remotely. They will call you, they will send the medications over to your house, and it'll be a remote check on your cases, on your symptomology, as well as follow through for up to 3 months of that particular treatment. So I'm actually going to stop at this point, and then take it again to Dr. Marco for now.
Okay. We are ready for the question and answer session.
I have one more section. It's pretty quick, but I think it goes hand in hand with Dr. Balani's next point about BA2. So,
Which one is it? Dr. Marka?
yeah.
Okay, give me 1 second.
All right. Am I on?
I'm just going to make you spotlight, Dr. Marka. Give me 1 second.
Okay.
Yeah, Marka, you are ready.
Okay. All right. Can you guys see my computer screen again?
Not yet.
Now?
Not yet. No.
Not
Okay.
yet. Yeah, I have enabled you to share the screen.
Yep, I got it. I got it.
Yeah, now we can see.
Perfect. Okay, great. All right. So I'm back again. So now onto our outlook. And alrighty. So as of right now, we're still in the pandemic phase. So the virus is still in the community and still infecting a significant portion of individuals, although the numbers remain low in perspective. However, we will eventually transition into the endemic phase where we will learn to live with COVID-19. So COVID-19 would not be the first ever endemic disease. Think of the flu. I think the flu is a perfect example of an endemic disease. Constantly in the background, has increased activity during certain months, and every couple years we have a very contagious and lethal strain of the flu. But eventually things calm down and go back to its normal low level of spread. So we are not there yet with COVID-19. However, we will get there in one way or another. And we will likely see more variants that evade vaccines, cause more severe disease, and lead to lockdowns, quarantines, and strict public health policies. This is certain. And also, COVID-19 vaccines will likely be a part of life as well. We will likely require 1 to 2 shots yearly that will be tailored towards the most contagious and significant variants of that season or year. When will that happen? We don't know, but all we can do is prepare. So I'm going to start off with some questions. So one question was, what are the standard guidelines for isolation after COVID-19 exposure and infection? And these guidelines have tended to change quite a bit. However, the thought initially was to isolate and quarantine for at least 10 days after infection or exposure. These guidelines have changed for a variety of reasons. One of the reasons is Omicron is more mild and possibly thought to be less contagious after 5 days of symptoms, given that your onset of symptoms is quicker than the previous variants. The second reason is public health officials have kind of lost faith in people abiding by 10 days and thus shortened it to 5 days to possibly increase compliance. And then there are a few studies from South Africa that showed there was a decreased transmissibility of disease after 5 to 7 days. So our next question is, can you get reinfected with COVID-19? And what about the same variant? So to simply answer the question, the answer is yes. You can become reinfected with COVID-19. However, it seems prior infection is protective against symptomatic disease. You can see this further in the other table, the bottom one from the New England Journal of Medicine, that severe, critical, and fatal disease was extremely low in those who were reinfected. You are more likely to be reinfected with a newer variant that has significant changes to the architecture of the virus, which allows it to evade the immune system better. So remember our story of Omicron. The changes to the spike protein allowed infection of those who were infected with Delta and previous variants, and those who were already vaccinated with 2 doses of the vaccine, but not so much the third. Albeit in all those cases, their disease was more mild. And can we safely say that COVID-19 is no more, or should we have to worry forever? So as I mentioned earlier, COVID-19 is here to stay. We have a new roommate. We must learn to live with it so we can avoid as much conflict as possible. However, latest data is showing a subvariant of Omicron, Omicron 2.0, which is slightly more transmissible than the original Omicron. However, it is not very clear that it causes any more symptomatic disease than Omicron, the original Omicron. One troubling thing, though, that's coming out of some data is that this variant is a little bit more elusive to traditional treatments. So Dr. Villani eloquently described some of our treatments, and one of those being sotrovimab, which is a monoclonal antibody meant to bind up the virus to prevent you from getting sick. And this particular strain of the virus actually evades and makes that type of monoclonal less useful. However, the other therapeutics she talked about should be still useful even against this variant. Now, there's still more that we don't know about this virus, and more is to come in the next few weeks or months. However, from what we are learning so far, it doesn't appear to lead to another round of illness and hospitalizations, as overall spread in the community is relatively low. Alrighty, and that's it for me. Hello?
Okay. Thank you, Dr. Markov.
Yep.
Dr. Jyoti, could we go on to the question and answer session?
Sure. I welcome all to the Q&A panel.
Give one second. One second. Yeah.
So as you've heard, Dr. Balani treated the very first case reported in New Jersey at Hackensack. Dr. Balani, can you please tell us your experience taking care of the very first patient? And was it any different compared to the ones that you're taking care now?
Okay, so taking care of that first patient was you can't really explain that sensation that you had. I think it was fear. It was unknown, the fear of unknown, the fear of the virus, the fear of repercussions if you didn't do the right thing or not know what to do, was all inclusive. I have to admit, though, that particular first patient really helped me, and I guess the whole of the medical community at our place, to really learn what the virus does at that particular time. He really followed the day-to-day or the week-to-week presentation so well to the book that we came to know later on through and through. So I think learning through him and was also just as important. The unknowns of how it was going to be transmitted, how how much gear are we supposed to be wearing to go inside? Are we supposed to put hoodies on? Are we supposed to put our hats on? Are we supposed to do this? We were literally in a war zone, not knowing exactly how to take care of him. But he thankfully did do well. He did go through all the stages. He was mild when he came in. He had the fevers, he had the chills, he had the diarrhea. He went on to get more short of breath. He went on to be from nothing to nasal cannula very quickly, up to high flow very quickly. Thankfully, he was not intubated, but he did the groaning. He did everything that had to be done to get him better. He was in the hospital for nearly 2 weeks. He was our first patient, obviously, with even remdesivir that we had to get through at that particular time. Learning how to get compassionate care of remdesivir was another thing that we learned with him and along with him. Use of steroids, should we give him a very big dose? Should we give him a little bit? Use of hydroxychloroquine, use of lopinavir, anything that was available to be used at that point was thought about. Simultaneously, along with that particular patient's arrival, we also saw the imaging studies. We saw how the CAT scans changed from nothing on the lungs the first day to a little bit of that white fluffy thing on one side to bilateral fluffy things over a very few, very quickly progressing on the CAT scan. So he really followed the COVID spectrum to the book. But again, through him and through the others that followed very closely thereafter, we really had a lot to learn, and that we did learn very fast. It was a very steep curve. And it's still a learning curve. It's still a constant changing living situation. It's you never have a guideline that is static or for even a few weeks. Like even today, I had to look up just to make sure that my booster dates are right. It's okay, it's 3 months. It's no longer 5 months. If that was 5, a couple of weeks ago. Or there's a new medication today that has to be put onto the system. So again, it's been a very fast moving target, continuously changing in front of our eyes, with our regimens changing continuously, proactively going forward. So I think it was a tough situation, and I think all of us were in the same boat. I think at that point, everybody was an infectious disease doctor, whether you were an OBGYN, or whether you were an allergist, where you were a dermatologist, you were a plastic surgeon, you were an ID doctor, because everybody was treating COVID left and right with the amount of cases that were coming in. So it was a tough time, but it was, hey, we worked through it, right? It's 2 years now.
Yes, that's right. Okay, so the next question would be for Dr. Farhan Far. We've all struggled with critical supplies shortages, the need for ventilator during COVID-19 pandemic, especially in 2020. Dr. Far, why do you think patients needed ventilator in 2020 more so than lately?
Well, in 2020, we didn't really know as much as we do now about COVID, obviously. Patients can tolerate relatively low oxygen saturations a lot better. And also in 2020, we were too quick to put people on a ventilator. It's really scary when you look at somebody's oxygen, and they're on room air in the morning and they're comfortable, and by 4 o'clock in the afternoon, they're on 100% non-rebreather mask. And that's why at that time we used to intubate people. In Chilton, we have a 12-bed ICU, and at one point we had 57 intubated people in the hospital, which was quite overwhelming. Now we have other tricks to use. We use high flow oxygen. We use prone ventilation. On really bad patients, you can use BiPAP for a period of time. And by using these tricks, you can avoid intubating people. One of the problems with intubating people is that we try to achieve normal oxygenation or close to normal oxygenation. And because it wasn't possible, we were using very high PEEP. PEEP is positive end expiratory pressure. And by using really high PEEP, we were actually causing more lung damage. And these people were then getting stuck on a ventilator for a long, long period of time. I had a patient 58 days on a ventilator until we got him off. That was on the first wave. Now, even if we have to intubate somebody, we try to do the prone ventilation, which obviates the need for high PEEP and prolonged ventilation. And so that's the main reason. We got better at it.
Yeah. The next question will be for Dr. Marku. The last variant was Omicron. Any insight into the future COVID variants? Will the future variants be more lethal than the previous variants? How do we prepare ourselves for the future variants?
Yeah, so I mean, we're bound to have more variants. I mean, it's just the nature of the disease. Whether or not they're going to be more lethal or more transmissible or a combination of both is unclear. I mean, if you look evolutionarily speaking, the more transmissible a virus becomes, the less lethal it becomes. So we hope that COVID kind of follows that, although it did break the rules when, it mutated into Delta. So it's kind of unclear, but, we have to kind of be on top of our testing and do a lot more genotyping studies and kind of ramp up and kind of try to emulate other countries that are ahead of us in that, like Sweden, Finland, South Africa, even India for the most part. They are, I would say, even farther ahead than the US in regards to picking up and early detection of variants and things that could become an issue.
I think the other part also that I would also add on is the variants occur when there's high viral presence, right? So if we can get the whole global vaccination programs to occur, which probably will be yet another 2 to 5 years, if not more, to really occur, till that time, there are going to be pockets where the virus is really replicating super fast. The more virus it replicates, the faster it replicates, the more errors it makes. The more errors it makes, the more variants we get. So again, trying to decrease the amount of virus in the community is the only way that we can get these variants under control. And the only way to get the amount in the community to come down is to have vaccinations pretty much worldwide. Now, as Dr. Marco had shown you one particular slide, there was like splay going from like 75 to 85% vaccination rates to Kenya being 4.5% vaccination rate. It's like, when is Kenya going to get up there? So again, to get to that point of mass vaccination, till that doesn't happen, which will be a couple of years from now, I think the variants are going to be there.
Yeah. So Dr. Balani, how long should one wait to get the booster dose after being infected with COVID? What's the validity of the third shot? And who should consider the fourth shot? I think you have already answered it, but that was the question that was posed by the audience.
So with the first part of the question being who should get who should get the vaccine, right?
If someone had COVID, how long?
Oh yeah, when should he get the vaccine?
Yeah,
Sorry,
yeah.
when should he get the vaccine?
Right.
So the only thing is basically following the CDC isolation guidelines. So if you've isolated yourself for 5 to 10 days, after the 10th day, you can actually go forward with getting the vaccine. You don't have to wait anymore at that particular time. So the most important thing is getting vaccine early on. After the 10 days part is all that you have to wait for. And that too is more related to preventing the virus spreading when you're going to a vaccination center. So that's the only reason why you wait the 10 days, but otherwise you can get it 10 days. Regarding who should get the booster shot, everybody above the age of 12 should get the booster shot. Who should get the fourth shot? Or technically speaking, it should be who should get 3 in the primary series, because the booster is only 1, but the primary series is a set of 3 doses instead of the routine 2 doses. And that should be the patients people who've got more advanced immunosuppressed state. For example, those who are undergoing chemotherapies, those who are getting cancer treatments, those who've had transplants, those who've had treatments with things like Rituxan, which is being used for rheumatoid arthritis or Crohn's disease, or have severe advanced HIV disease, or have immunodeficiencies that may not allow them to mount a response very well. Those patients should get 3 in the primary dose, and then the fourth shot is the booster shot.
Usual comorbidities like diabetes, hypertension, obesity are not really included for fourth dose, correct then?
Correct.
Yes.
As of now, it is not. What is important is making sure that your vaccine booster is taken at a timely manner in those patients to prevent progression of disease.
Sure. So the next question would be, what are some of the serious post-COVID symptoms to be observed or watched? How to effectively manage post-COVID symptoms?
I guess I could take that. I can start. I can do a couple, and I'm sure everybody will have something to add on. So I guess I could start with fatigue and the psychological anxiety or the depression that comes along with having COVID and being fatigued for a long period of time. You don't realize how tired you can get. Like, you could be very, young and healthy and exercising prior to COVID, and then you get COVID, and for the next 3 to 4 weeks, it's amazing the amount of time you can sleep. I remember that. I slept 20 hours in a day for nearly a couple of weeks till I could really feel better. So again, fatigue is a very common post-COVID issues. Anybody who has symptoms more than 4 weeks after completely getting well from COVID usually is termed as being a post-COVID syndrome or a long hauler, as you can call it. From the first primary stages, there are people who still have anosmia, no smell. The smell has not come back. Taste changes have happened, which could also be a prolonged thing. We don't see the smell and taste issues with the Omicron wave as we did in the first few waves. You could have that for a prolonged period of time. You could have GI illnesses or diarrhea that can be present. You can have exacerbation of rashes that can be present in this particular patient population post-op. There have been cases where they have eczema that has been really uncontrolled after they've had COVID, and again, don't know whether something stimulated it or whatever it was, but that was persistent. In those who've been on the ventilator and had, scarring and sequelae from severe lung damage, have pulmonary fibrosis and scarring in the lungs that has required them to be on oxygen for a prolonged period of time. And Dr. Farrar or Dr. Marco, do you want to add on more?
No, you did a pretty nice job of summarizing most of them. The other thing is brain fog, so difficulty in concentrating and whatnot. People, forgetting their train of thought as they're in conversation. The rashes is actually quite an interesting one. I'd probably say over the past 2 to 3 months, I've become a bootleg dermatologist because everybody's coming up to me and asking me, what does this look like? I had COVID about 2 months ago. And looking into the literature, it looks like there's a dermatomyositis-like presentation that kind of happens in people who have had COVID a few months back. And dermatomyositis is basically an inflammatory disorder of your skin and muscles, and it leads to these kind of significant rashes throughout the body, mainly in the legs, and not so much the upper extremities or the face, but it can be seen throughout the entire body. So most of these things are self-limited, meaning that they'll get better no matter what anybody does, and you just have to have patience and just kind of a will to get through it, and you will get through it, but it's a process, and it's a lot more common than what we think. I think some of the latest studies showing at least a third of patients have some sort of long COVID-like syndrome. So it's quite common.
And as far as breathing is concerned, shortness of breath for long periods of time is probably the second or third most common long COVID symptom. This also is self-limited. Doctors have used inhalers, but really it doesn't do anything. And if you just do supportive care, maybe some pulmonary rehab, all of this will resolve in time. I've done pulmonary function tests on probably 500 plus COVID patients, down the road, and it shows mild restrictive disease from the scarring from the inflammation. And of course, the milder the disease was, the more normal their breathing test, but nobody has really horrible, lung function. So that's a positive thing for the future.
There's also another syndrome called POTS syndrome, which is basically postural orthostatic hypotension syndrome, where we've seen patients when they are going from a laying position to a standing position, they have been very dizzy or they become very lightheaded and they drop their blood pressure. So this is something that there is a dysregulation that occurs in their cardiovascular system that can also be presented in these patients post-COVID.
So the next question would be, when is the safe time to start indoor physical meeting or gathering? What are all the guidelines for unvaccinated attendees during this gathering?
Have fun.
That's a little bit of a controversial question. I mean, I guess you have to look at community spread, right? So if you have relatively low level of community spread, then it's probably okay to have a small gathering. I wouldn't, have a, gigantic gathering at a house and have everybody on top of each other. But I mean, within reason, if you're going to, have like a small party or a little get together, I would be safe. I mean, for the Super Bowl, I had 10 people over. So, take for what it's worth. So yeah, and that's my 2 cents.
They should all be vaccinated though.
Yes.
Right.
Yes. Yeah. Right. So provided the vaccine status, I think it's important. I think it's more, it's a personal level, and then it's at the community level that you really have to be looking at. So in the globe of things, I think you need to really look at what your transmission risk is, what your level of activity is. There's actually a very good website that you can go on to CDC to check for your community level COVID situation that's going on. So suppose you're planning to travel, like my husband's traveling for skiing to Colorado, to the Summit County. All I have to do is put in Colorado State, I have to put in Summit County and actually check for the level of community COVID that is present around. So it kind of grades you to low, medium, and high risk, depending upon the number of new cases per 7-day period, as well as number of new hospitalizations in the last 7-day period. So based upon the community level of spread, it kind of goes into low, medium, and high. So if you're going into a low community risk of having this disease and you yourself have a very good immune status and you're not putting yourself at risk or you're all vaccinated, I think it's okay to be without the mask. On the flip side, you are going into a high community spread areas or low vaccine rate space, then I think you really have to make sure that you have your mask on and you know what your risk of transmission would be. Also, if you're going into low community place, like Bergen County is currently low community spread, but I'm on transplant, I am not going without my mask. So again, knowing what's happening around you and knowing what is your risk is going to be important, especially with the new guidelines that just came out regarding no mask requirements, right? So no mask requirements doesn't mean that, oh, COVID is gone. No, what it means is COVID is around. You need to take the responsibility now. Government is not going to tell you what to do. So I think it's very important now, more so than before, where the mandate was universal. Now it is personalized, and you have to be personalized about it, knowing when you should or should not be wearing your mask.
Yeah. So there are thousands of anti-COVID vaccine mandate protests around the world. Dr. Farr, what's the message you would like to give for someone who doesn't believe in vaccination against COVID?
Believe in it.
Round a day with us on the unit, and then have them believe.
Sure.
True. Have the various vaccine versus unvaccinated status around for people to actually see what the stark difference there is in those who are vaccinated versus unvaccinated regarding severity of illness and death. It's crazy when people even have to think about taking the vaccine.
Okay, let me check if there's any questions. That's about it. Yes, I think
Just one more actually talk. Just going through with that same question. Now, forget the anti-vaxxers, but there are some population of patients where they can't take the vaccine for whatever personal immune reasons or reaction to the vaccines or whatever the case may be. There's a major reason why they cannot take the vaccine. In that situation, and there's another patient population where they can't mount a response to the vaccine, right? So they've taken the vaccines, but they just don't have the antibodies because they are on CAR T studies or whatever. There are options now available called Evusheld, which is basically a monoclonal antibody that you can infuse that will stay in your system for nearly 6 months to be as a pre-exposure prophylaxis against this particular virus. So you can actually get passive immunity by taking that particular monoclonal antibody to prevent you from getting the disease.
Okay, that was a very nice point.
Dr. Jyoti, at the last moment, we got one more question. It's probably a myth.
Okay.
Does COVID have any impact on the fertility? Will it increase the miscarriage amount?
Yeah, so we do know that COVID-19 increases the mortality risk of the baby and the mother significantly, which is why we put them in the high-risk category. I mean, just at St. Clair's alone, over the past 2 months, we had 4 pregnant people die from COVID and being pregnant. Both the mother and the baby died. So it is a significant risk factor, and all those people were unvaccinated. So it's extremely important to have pregnant women get vaccinated.
I think the question is probably, does COVID vaccine have any impact on the fertility? I think
from the vaccine perspective, there's no data to suggest that it impacts fertility. However, there is some data that shows that it may change a woman's menstrual cycle, but it does not have an impact on whether or not she is able to bear children at a later date. Again, this is still a relatively new vaccine over the past year, so we're still learning about it. But from what we've seen so far, there's really no impact on long-term fertility.
Just to clarify regarding the menstrual cycles, it's not that they become amenorrheic, they actually have increased bleeding cycles. So again, it's not that they lose out on the menstruations or whatever, decreasing the risk of fertility. It's more just that there's slight increased risk of heavier bleeding.
I think there are no questions came. I think those are all the questions we received so far.
Okay, sincere thanks to VSNY-NJ for organizing the event, and I hope the discussion was very helpful. Our heartfelt gratitude to our delegates, Dr. Marcoux, Dr. Balani, and Dr. Farinfar, for your valuable time and effort. We sincerely thank you for the session.
You're welcome.
Also, thank you, Dr. Jyoti, for bringing the guest speakers to this occasion, and thank you very much for organizing this also. Thank you again. Okay. Thank you all. Thank you all. Good night, and have a safe weekend.
Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you.